Hello everyone and welcome back to Pain School. Today we will be talking about pain to addiction, preventing, identifying, and treating opioid use disorders. We would like to thank Dr. Jenny M. Rosinski, a psychologist in the Substance Use Disorder Clinic, for the creation of this presentation. So first, let's look at some very startling statistics. In the United States alone, 130 people overdose on opioids every single day. Back in 2016, 48.5 million people in the U.S. reported use of illicit drugs or misuse of prescribed drugs, and only 2.2 million of those received some sort of treatment. Of all the patients prescribed opioids for chronic pain, about 21 to 29% misuse them, and between 8 to 12% develop an opioid use disorder. An estimated 4 to 6% of people who misuse prescription opioids transition to heroin. And while this might not seem like very much, about 80% of people who use heroin first misused prescription opioids. This is a quick look at the total annual overdoses by state in the United States back in 2021. As we can see, some of the more prominent states, such as California and Florida, may be obvious because they have higher populations. But you can see that even some of our more rural states or states with lower populations still have a large number of annual overdoses. Overdose death rates have been increasing and have been on the rise since the 1900s. This particular chart, spanning from 1999 to 2020, shows this increase. So as we can see, in the green line here, this is any type of opioid. And this was on a pretty steady incline until about 2013, where you can see a very large spike from 2013 to 2017, which has then only rapidly been increasing since then into the 2020s. This large increase of any opioids is mostly attributed in the last 20 years to this category in purple, or our other synthetic opioids, the biggest being fentanyl, which has become more prominent over the last decade, and is also a very large component in many of these opioid deaths. The blue line here are our commonly prescribed opioids, which we can see did increase at a pretty steady rate from 1999 to about 2010 or 2011, and then has kind of stayed at roughly the same area since then. Our orange line is our heroin, which we can see rapidly increase starting in 2010, but has been slightly on the decline from about 2016 on. The National Center for Health Statistics provided much of this information on the drug overdose death counts. And as we can see, just in the jump from January 2020 to January 2021, there was over 22,000 more deaths, or a 30% increase in deaths in just 1 year. And that was a few years ago now. So what is an opioid use disorder? Well, we use the DSM-5 criteria when we make this diagnosis. The DSM-5 criteria states that having 2 or more of the following qualifies as having an opioid use disorder. Let's go through those. First being a craving or strong desire to use opioids. An example of this would be constantly thinking about the next dose. Recurrent use in hazardous situations. This could be, for example, driving while impaired or finding yourself in dangerous situations while using the medication. Using larger amounts of opioids or using for over a longer period of time than intended. This might be seen in requesting for early refills or needing more than the prescribed opioid. Next is the persisting desire or inability to cut down or control opioid use. This might be, for an example, having a difficult time tapering from some of those pain medications or opioids. Spending a lot of time to obtain, use, or recover from opioid effects. This might be spending lots of time driving from different doctor's offices to obtain opioids, or having to use sick time or take up many hours during the next day to recover from some of those effects. Continued use despite knowing that opioids are causing medical problems. So continuing to use or request opioids even after having an overdose, or having symptoms such as really bad constipation causing a bowel obstruction, etc. Continued use despite knowing that opioids are causing social or interpersonal problems. This is a really big one. An example of this could be continued use despite performing poorly at work or having trouble with family life. Failure to fulfill obligations at home or work. So an example would be neglecting tasks that typically were not being neglected prior to use. So not getting done the cleaning, gardening, or paying bills, or not completing projects at work as you normally would. And lastly, giving up activities or reducing activities because of use. So no longer doing activities or reducing activities that you enjoy to supplement instead with opioid use. So this could be no longer spending time with friends, playing games or sports, or spending time with family, and giving up those activities or reducing activities to use opioids. Next, let's talk about the 3 C's, because truly addiction is not just about using or misusing drugs. It's about the behaviors surrounding those drugs. The 3 C's are cravings, compulsion or loss of control, and continued use despite harmful or negative consequences. So why can't you just stop using? Well, opioids elevate a chemical in the brain called dopamine. This is the feel-good hormone that provides a happy sensation in response to different things that we experience. Tolerance can occur, which is where smaller and smaller amounts of dopamine is released per unit of drug. This means that more and more of the drug has to be used to get that same happy feeling. This all tricks the brain into thinking that this opioid or the drugs are necessary for survival, which then continues to contribute to the problem. The VA has come up with some strategies to address the opioid epidemic. The first is to change the way that we treat pain and prescribe opioids. This includes promoting non-medication options for treating pain, such as acupuncture, chiropractic care, physical therapy, cognitive behavioral therapy for pain, yoga, and more. Most of this can be found through the whole health initiatives. Also, by incorporating more non-opioid medications in regimens to treat pain. This includes our non-steroidal anti-inflammatory drugs such as ibuprofen, acetaminophen or Tylenol, medications used to treat depression. Some of these can help specifically with peripheral neuropathy or nerve pain, and more. Another strategy is overdose prevention, by making sure that we are providing Narcan or naloxone to any patients that are prescribed opioids. This is the opioid reversal agent that can be used in response to overdoses. Also, medication-assisted treatment. We'll talk a little bit more about some of the medications that we can use to treat opioid use disorder later in this presentation. So what are some signs of opioid overdose that we can be aware of? pinpoint pupils or really, really small pupils, unconsciousness, shallow or slow breathing, pale skin, blue lips, or snoring or raspy breathing. In responding to an overdose, we should first check for a response. We should do this by lightly shaking the person, yelling their name, and firmly rubbing on the person's sternum, or that bone in the center of the chest where the ribs connect. Hold the hand in a fist and push the knuckles into that sternum and rub firmly. If the person does not respond, give naloxone and call 911. If you have the naloxone nasal spray, be sure not to prime or test spray before giving it. Simply insert the tip of the nozzle gently into one nostril and press the plunger firmly to give the entire dose of naloxone to the patient. If you have the auto injector, pull the device from the case and follow the voice instructions. When calling 911, be sure to give the address and tell them that the person is not breathing. Always make sure that the airway is open if someone is not responding. Next, you want to make sure that you can give rescue breathing if the overdose is witnessed. To do this, place a face shield, if available, over the person's mouth, tilt their head back, lift the chin, pinch the nose, and give one breath every 5 seconds. Be sure to watch their chest and make sure that it's rising. If their fall or collapse was not witnessed, skip breathing and switch to chest compressions. To do this, kneel to one side of the patient and place the heel of one hand over the center of the person's chest between their nipples. Place the other hand on top of the first hand, and while keeping elbows straight and shoulders directly over your hands, use your body weight to push straight down at least 2 inches into their chest at a rate of 100 compressions per minute. If the person doesn't start breathing in 2 to 3 minutes, or if they respond to the first dose but then stop breathing again, you can give a second dose of naloxone. Because naloxone wears off in 30 to 90 minutes, make sure to stay with the person until medical staff arrives, or for at least 90 minutes in case the person stops breathing again. Lastly, if the person is breathing but unresponsive, put the person in a recovery position. Do this by laying him or her on their side to prevent choking if they vomit. So, a word about safety. What are some steps we can do to improve safety? 1. Do not consume alcohol with any opioid. This can increase the risk of respiratory depression or increase the risk of having breathing difficulties. 2. Talk to your doctor about other medications you take that may increase the risk of an accidental overdose. 3. Keep your medication in a secure place, such as a lockbox, to prevent someone who shouldn't be getting into it from having exposure to the medication. 4. Dispose of all unused medication safely, such as utilizing a drug take-back program or mail-back programs through the pharmacy. 5. Do not take medications that are not prescribed to you. And 6. Notify your VA provider if you take non-VA prescribed medication so that they know everything that you are taking at home. Next, let's talk about some options for medication-assisted treatment of opioid use disorder. One of the medication options that we have is called naltrexone. This medication works by binding and blocking opioid receptors and reducing opioid cravings. A good thing about this medication is that there's no potential for abuse or diversion to other people. However, to use this medication, a person must be detoxed from an opioid before initiating it to prevent what we call precipitated withdrawal, or throwing someone into withdrawal because of the medication. It's recommended that patients abstain or stop taking opioids for at least 7 to 10 days prior to starting. Some programs even recommend 14 days. Withdrawal can be really painful and difficult. Some signs of withdrawal include nausea, diarrhea, anxiety, irritability, sweating, chills, insomnia or inability to sleep, pain, muscle aches, and cramps. It's important to note that oftentimes patients have access to detoxing, such as in a program or at a hospital, but oftentimes not access to treatment. With naltrexone, it's important to remember that because of how it binds and blocks opioid receptors, if a patient relapses or starts using opioids again, they have a very high risk of opioid overdose because this medication removes that tolerance to opioids. Another medication option is methadone. Methadone is a medication that's been used for decades in opioid use disorder treatment. This medication changes the way that the brain and nervous system responds to pain and blocks the euphoric effects, or those happy feeling effects, of opioids. When using methadone, patients must be closely monitored, and it often requires daily administration of the medication when initiating. This is in part because methadone has some of the highest risk of opioid overdose of all the medications that can be used to treat opioid use disorder. It also has a higher risk of diversion and misuse. The last medication option that we'll talk about today is Suboxone, or buprenorphine naloxone. This is a partial opioid agonist. It diminishes the effects of physical dependency to opioids, such as withdrawal symptoms and cravings. It has less potential for overdose and requires less frequent visits. It can also be provided in any treatment setting, and it no longer requires a special waiver on a DEA license to prescribe, which means that it's much more easy to access now. So what are some myths about these medications? The first is that methadone and buprenorphine do not substitute one addiction for another. When someone's being treated for an opioid addiction, the dosage of medication used does not get them high. It just helps reduce opioid cravings and withdrawal. These medications restore balance to the brain that has been affected by addiction, allowing the person's brain to heal and work towards recovery. Another is that diversion of buprenorphine is uncommon, and when it does occur, it's primarily used for managing withdrawal. Diversion of prescription pain relievers, including oxycodone and hydrocodone, is far more common. In 2014, buprenorphine made up less than 1% of all reported drugs being diverted in the US. So what are some treatment program options? Within VA Eastern Kansas, some options include the Leavenworth Substance Use Disorder Clinic, the Topeka Substance Use Disorder Clinic. These are outpatient programs. Some inpatient programs include the Leavenworth Domiciliary, which is a 90-day residential treatment program, and Startup at Kansas City VA, which is a 21-day residential addiction program. Talk to your provider about a referral to these programs if you're interested.